So today we will be discussing acute liver failure and what's different in pediatrics as compared to adults. There is certain differences from definition to etiology to native liver survival and in management as well. So we have different definitions. The definition of us is biochemical evidence of liver injury, coagulopathy not corrected by vitamin K, iron more than 1.5. Encephalopathy or more than 2 without encephalopathy, and there is no known history of chronic liver disease. In adults, the coagulopathy definition cutoff is 1.5, hepatic encephalopathy is mandatory. That's the difference. In adults, it's a encephalopathy based definition, but in children, we can even level it as a pediatric acute liver failure without encephalopathy because of the difficulty in assessment of encephalopathy. And in adults, it's not a common practice to give vitamin K, but in pediatrics, we give vitamin K routinely at least. There is another definition that is called acute liver injury. That is severe acute liver injury with an INR more than 2, but without encephalopathy. We include that definition within the context of the liver failure. And now we are moving towards a newer definition in which it remains same. The duration has been defined as 8 weeks, and the biochemical evidence of liver injury is more clearly defined now. AST/ALT more than 100, GGT more than 100, total bilirubin more than 5, and total direct bilirubin more than 2. Our etiologies are also a little bit different. This is adult data what I am showing here from the ALM study group, mostly from Western countries. 2,600 patients, and most common was paracetamol, second most common was indeterminate etiology. This is again from the West, but it is a pediatric data from PALM-SG group, 1144 children. Most common was indeterminate and second was paracetamol. But what we see in India is totally different. We still, this is adult data here I am showing, still acute viral hepatitis is most common even in adults. A small proportion remains in Wilson or autoimmune hepatitis, and drug-induced liver injury and indeterminate etiology in which we do not find any etiology remains a significant, at least 20% of the cases within that context. In children also, it's A or E is the most common one. Wilson around 10%, and drug-induced liver injury and indeterminate around 20% of the cases. In the lower part, I have shown few recent data that they are reporting, mostly reporting from the pediatric ICU care centers. They are reporting dengue coming as 6 to 15% or up to 20% of the cases contributing to the pediatric acute liver failure. Although ideally we don't include dengue as in the context of acute liver failure, because here the liver is involved as a part of systemic illness. So that's why we exclude tropical illnesses like dengue, malaria, strep typhus, other than pediatric acute liver failure. Then our etiologies are different in the age-wise from birth, gestational alveolar liver disease, then coming to the herpes simplex virus, then in the early infancy, galactosemia, thalassemia, and going on to viral hepatitis, drugs, Wilson disease, autoimmune hepatitis, or even indeterminate in the older children. What we see here in Jharkhand is the most common is acute viral hepatitis, mostly A in children, in older children or adults is E, and followed by herbal drug-induced liver disease. So this is the common ratio here I have shown here. In the 2008 study came, ALP by bilirubin less than 4 and AST by ALP more than 2.2 was shown to be having very good sensitivity and specificity in adults. This is adult data. But in children what we have is not so good. The first one has around 71% sensitivity and the second one was 52%. Combined it was only 49%. So diagnosing Wilsonian crisis becomes more difficult in children. Then our outcome is also different. In the top 4 first action transplant-free survivors, it's varying from 50% to 65% depending upon the etiologies. In lower part, adults transplant-free survivals are shown, it ranging from 20 to 70%, but overall the outcome is a little bit better in children as compared to adults. The reason being, we have a pre-morbidity normally, but we start with most of the cases, and our starting point is cirrhotic liver in Wilson and IH was very small proportion of the cases, and that is leading to massive necrosis. And the other thing is that we have a different regenerative capacity. That's at least we want to believe, not much data to support, but at least we want to believe that we have a different regenerative capacity. So here I will be showing two data. So these are APO-LT data. So this is auxiliary partial orthotopic liver transplant data, post-transplant outcomes here I am showing. So they don't remove the native liver. They keep the native liver as it there and a small graft is implanted. So they keep on following years after years and they keep on doing liver biopsy of the native liver year after year. And these two studies, one from King's College and another one from Philadelphia, they showed that 82% of the first study there was native liver regeneration, total native liver regeneration, and then thereafter whenever there was liver regeneration, they started withdrawing the immunosuppression. So by the time graft liver will be gone. So this patient can be saved with the native liver with the intermediate crisis period being taken over by the graft liver. So this is a very good concept, difficult to prove and difficult to do it because it's surgically challenging also. And in the lower study again 92% had a native liver regeneration and immunosuppression could be withdrawn in around 75% cases by the time the study was published. So these are interesting to know but difficult to prove in Indian setup. Then what is unique in our cases, we have a condition called hyperacute liver failure. It's seen more in the children as compared to adults. And the outcome is very good with a good quality pediatric intensive care setup. This one was from PGI Chandigarh, or from where I did my DM. The jaundice to encephalopathy interval 7 days is the criteria used to define hyperacute liver failure. Only 11% died. It's an old study, we didn't have even good quality ICU. Ultrasound was not easily available, focus techniques are not available to the intensivist. At that time, only 11% deaths were there. Then this one from MD, this is from Lady Harris Medical College in Kalamath Children's Hospitals, 34% deaths. And this one included only hepatitis A cases from ILPS, recent data, again 13% deaths. So we have hyperacute liver failure cases, especially in case of viral hepatitis cases, and that so 10 to 30% deaths only. So up to 80 to 90% can be saved if we provide them good quality pediatric intensive care. Then the role of NSAID system in the management part. In adults, there is only one properly controlled RCT done by Lee et al. And there are few prospective studies. So all of them showed good native liver survival. So now the recommendation in adults is almost uniform. In non-paracetamol liver injury, you try NSAID system. But in pediatrics, we don't have such strong data. We have only one good quality RCT. But the problem was, although the overall survival was similar, the transplant-free survival was poorer in the NSAID system now as compared to the placebo one. So we use NSAID system selectively, not as a panacea for all. We use in paracetamol areas. Few of the non-paracetamol cases where there is duration of illness is less than 10 days or grade 1 to hepatic encephalopathy. Drug-induced liver injury, this is again from the adult study, subgroup analysis was there, and muscle or rat clear positive. It does not work in children less than 10 years. It is again a subgroup analysis of the trial, and when there is definite etiology present like autoimmune hepatitis, Wilson's disease, it does not work. So NSAID is for selected cases, not for all. So now we are progressing towards indeterminate ALS. This is one group where we don't have any etiology. Even after a basic workup, viral workup, we do workup for A, B, E, and celluloplasmin, sometimes autoimmune workup also, but we find nothing. So what we are trying to find out what is ongoing. In children, we always think it's genetics. So this group published in 2023, they did whole exome sequence of all the intermediate ALS patients. They show that up 37% of the cases can have a genetic background of liver failure. If we are not finding any infectious etiology, autoimmune or Wilsonian etiology, we should search for genetic etiology. And it was more common in recurrent PLS cases or less than 1 year old children. And most frequent genes were NBAS, MPP17 and DGUK. The lower layer 2 are mitochondrial hepatopathies. And most frequent genetic defects, as a group wise, mitochondrial genetic defects were the most common ones. Then this group again from Philadelphia, they are trying to find out what is going on here. So they are doing extensive immunostaining, CD8 and CD103 staining they are doing. So this group showing indeterminate PLF, and this group already has been diagnosed either Wilson or autoimmune or some other etiology. They showed that all these indeterminate cases are having more staining for CD8, perforin and CD103. So basically what is happening, these are actually mediated by the cell-mediated immunity. We do work for immunoimmunity by ANA, IgG, LKM, but we don't find them, all of them are coming negative, but again it is cell-mediated immunity. These are cytotoxic T cells, perforin and CD103, they are being staying here. So based on this data and the concept of acute indeterminate acute liver failure being cell-mediated, immunity-mediated, this trial is ongoing, most likely the results are expected by 2026 end. So it is a multi-specific data ongoing in USA. All the indeterminate cases will be included. A, E, B, C, HSB, AIH, Wilson, diagnosed liver injury will be excluded and diagnosed IM will be excluded. And the systemic illnesses like sepsis, irreversible shock, HLH, aplastic anemia, immunosuppressants will be excluded. So this is the group which used to define as indeterminate etiology PLM. 3 arms trial is ongoing there. ATG, methylprednisolone and placebo. So we expect something coming out of this trial. So if something positive comes, we can provide them some immunosuppression like by ATG or methylprednisolone. Liver support therapy, I will not be going into details because there is a separate discussion on plasma exchange therapy in the afternoon. So this is just a heading. We have PP, we have DPMAS, we have Prometheus, we have SPLE and MAS. But what happened here, in adult trials all failed. It was a series of failures of MAS, Fulmar trial, Relief trial, Helios trial, all one after another failed. As if to provide transplant-free survival, only they were used as a bridge to transplant. In adult, one good data came from plaques, that was RCT in adults, Western data from mixed etiology. Then another data came from mixed etiology from IMBS. This one this is standard volume plasma exchange. This was high volume plasma exchange. In children, now IMBS is generating lots of data regarding plasma exchange. They have shown it works even in the sickest of the pediatric acute liver failure cases by propensity score matched analysis published in here. Then subgroup analysis, they showed that it works in the sickest hepatitis A related liver failure. Then they have published one RCT and one propensity based data on Wilsonian liver failure. And CMC Velo is showing useful of plasma exchange in drug-induced liver injury, alcohol-induced liver injury, and in track killer, one study has been published from Tamil Nadu ISG group. So now plasma exchange is finding place in management of acute liver failure cases. Now transplant deficiency, this is the last one. We decide based on etiologies. This is the topmost part, green one, paracetamol, hepatitis A, E, and ischemic hepatitis. They are predominantly normally. So they are likely to recover spontaneously. So they most likely will not be requiring transplant. If we can provide them good care. In between there is lower burst mitochondrial, hemophagocytic lymphohistiocytes or herpes simplex virus. These are multisystemic illness. Even if you save the liver, it's not going to improve the outcome. So they are not good candidates for transplant. In between what happens, Wilson and AIH, the livers are actually cirrhotic. Although they are presenting as an acute liver failure, but they are actually cirrhotic cases. So they are unlikely to recover without transplant. So these are good candidates for liver transplant. And indeterminate etiology, PALP and DILI. So these are actually mixed injury patterns. One side inflammation is ongoing, one side steatolytic injury is ongoing, and many other injuries ongoing which are yet to be identified. So these are unlikely to recover without transplant. So these are the candidates for liver transplant. As hepatitis A is most important in our system, I have shown here the data about hepatitis A and E. These are pediatric data. The survival varied around 60 to 70%. Even from the older, this is 2022 and this one came as 2024. This is 2002. So the outcome is around 70% can be salvaged with pediatric ICU care itself. And hepatitis A, E, that's again from 2002 study, 65% can be saved. In adults, again, E's outcome is around 55% can be saved with ICU care itself. So if we send it for transplant very early, it's unnecessary transplant. If we send it late, the outcome is poor because now the encephalopathy has progressed to 3, 4 and multi-organ failure is already setting. So we have a window of sending for transplant between 3 to 4 days. So that by the time we have to take decision whether the child will improve or not, or it will require transplant. So do we have good prognostic markers? In adults, the markers are completely different. We have markers. Here I have shown only markers, multiple prognostic markers are used. Dynamic prediction model, CHAL, PAL, Delta 2020 and liver injury score 2006. But whatever it is, these are all combined scores. None of them have been found to be very good as a prognostic marker. People are trying, but none of them work very good. What is working here is etiology specific markers. One is the New Wilson Index, that is the Horn modification of New Wilson Index, published in 2005. That is working. If it is more than 11, it is a candidate for liver transplant. And PACE HAB model, which came in 2020 from ILBS, that is again working in hepatitis A related liver failure cases. So in our scenario, we are using this one PACE HAB model based on 3 parameters: jaundice to encephalopathy interval more than 10 days, hepatic encephalopathy grade 3, and INR after 1 dose of vitamin K more than 3.1. So these are the prognostic markers we are using in our day-to-day practice. Last slide is uniqueness of PAL in India. Etiology of infection in India is different from most developed countries. Acute viral hepatitis in children A and in adults E remains the most important in India. And supplemental indigenous drugs complicates the picture in most of the time on top of acute viral hepatitis. The background liver was mostly normal prior to acute liver event. We have a significant proportion of hyperacute liver failure, and so it highlights that even we can salvage at least 60 to 70% of the cases with good quality PQ care. So that's the point I want to highlight at the last slide, that sometimes it's the sick acute liver failure cases who cannot afford liver transplants. Our ICU team is the only one which is standing between Jamraj and death. So sometimes we have to say, Karman ne baadi karaste, ma phale su kadachana. Thank you.